This is the paper that was done in August 2008. By then, it was mainly questions for paper 4 because we had 4 papers by then, paper 1, paper 2, paper 3. But by today's standards, most of these questions will be found in paper 2. Remember, currently we only have paper 1 and paper 2. So let's get right into it. First question is that a type of schizophrenia characterized mainly by delusions of persecution and auditory hallucination is, we're looking at those options. B is the best option, that is paranoid schizophrenia. Paranoid schizophrenia is primarily marked by intense delusions and hallucinations, especially delusions of persecution and auditory hallucinations, while cognitive function and affect may remain relatively intact compared to the other subtypes. Let me also use this time to inform you about the other types of spectrums found here. We have schizophrenia, which is a chronic disorder with delusions, hallucination, disorganized speech, and negative symptoms. Schizoaffective disorder has features both of schizophrenia and mood disorders, could be depression or maniac. Schizophrenic form is similar to schizophrenia, but this one lasts between 1 to 6 months. We also have a brief psychotic disorder, which is characterized by sudden onset of psychotic symptoms lasting less than a month. Delusional disorder, where the patient presents with persistent delusions. We also have shared psychotic disorder, the Fuchs doxy. This is a delusion that is shared between close individuals, and this is now categorized as other specialized schizophrenia spectrum and other psychotic disorder. Psychotic disorder due to another medical condition where psychosis is caused by a medical illness. And lastly, we have substance or medication-induced psychotic disorder where psychotic symptoms due to substance or withdrawal. Question number 2. Postpartum depression typically appears on, postpartum depression typically appears on which days? Looking at all those options, as A is the best one, and this is the time that coincides with the sudden hormonal drops, especially estrogen and progesterone after delivery. If you look at the first to the second day, here you find women may experience postpartum blues or baby blues around this time, which is normal, and it includes mild mood swings and tearfulness. So postpartum depression typically develops within the first week after childbirth, mostly around the third or fourth day. This time coincides with the significant hormonal changes. So there is normally a drop in estrogen and progesterone after childbirth, which affects brain chemicals like serotonin and dopamine that do regulate mood. So this hormonal shift disrupts neurotransmitter balance, leading to depressive symptoms. At the same time, the hypothalamus, pituitary, and adrenal axis dysregulation may also increase cortisol levels, contributing to stress and emotional instability. Sleep deprivation, lack of support, and a history of depression can further increase the vulnerability. Genetic and psychosocial factors also play a role. So it's a mix of biological, psychological, and social triggers that normally leads postpartum depression. Number 3, a type of epilepsy in which psychological features are common is, now looking at those 4 options, and as D is the best one, you find that for the occipital lobe epilepsy, it primarily causes visual symptoms like flashes of light or visual hallucination, while parietal lobe epilepsy causes sensory disturbances such as tingling or numbness, and which are psychological features. In here, you find psychological features will be rare. Frontal lobe epilepsy often presents with motor symptoms, bizarre movements, or sudden behavioral changes, but less commonly psychosocial aura here. So the best one is temporal lobe epilepsy, which is the common type, the most common type of focal epilepsy, and is often associated with psychological and behavioral symptoms, which include fear, anxiety, and emotional disturbance, hallucinations, especially the auditory or olfactory, complex partial seizures with impaired awareness, and memory disturbances and personality changes with chronic cases. The next question is reciprocal inhibition involves. Now looking at all these four NASes, NAS C is the best where you are trying to elimination of behavior by introducing a more adaptive behavior which is incompatible with the unaccepted behavior. So number one, you find that this one is referring more to flooding, not reciprocal inhibition, while NAS B, this is the part of systemic desensitization, but the core mechanism in reciprocal inhibition is via relaxation, which is not there. NAS D, you find that this describes timeout, which is a form of behavioral punishment and not reciprocal inhibition. Reciprocal inhibition is a concept from behavioral therapy, especially associated with a scientist by the name Joseph Wolf, where anxiety is reduced by introducing a response that is psychologically incompatible with anxiety. For example, in this case, relaxation. So instead of being anxious when exposed to a phobic stimulus, the patient is trained to relax, which inhibits anxiety response. This principle is key in systematic desensitization, where relaxation, which is a more adaptive behavior, is used to counter a condition, which is the anxiety response. Number 5, a behavior therapy technique used in treatment of sexual aversion disorder is, looking at NAS A up to D, find that NAS A is the correct one, right? When you look at B, systemic desensitization, this is normally used for treatment of phobias and anxiety disorders and not specifically tailored to this sexual aversion. Squeeze technique, on the other hand, is used to treat premature ejaculation and not sexual aversion. And lastly, modeling involves learning through observation. So this one is normally used in phobias and or social skill training, not typically for sexual aversion. Sensornet focus. Sensornet focus is a behavior therapy that was developed by Masters and Johnson and primarily used in treatment of sexual dysfunction, including sexual aversion disorder, performance anxiety, and intimacy issues. Sensate focus involves structured, non-demand touching exercise between partners that are designed to reduce performance pressure, increase awareness of the physical sensations, and build intimacy gradually. And this helps to replace anxiety with pleasurable and relaxed experience. Number 6, codependence means. Codependence means, now when you look at our NAS A up to NAS D, you find that NAS A is the one who is giving us the best treatment. Dysfunctional behavior is evident among members of a family of a chemically dependent person. So NAS B, this refers to peer influence or group addiction and not the codependence that is being asked about. NAS C describes shared substance abuse, not codependence, while NAS D is too broad and inaccurate. Family dynamics are key in codependence. That is what you want to know. So codependence refers to a dysfunctional pattern of behavior exhibited by individuals who are closely involved with someone who has a substance use disorder, typically the family members. These individuals may enable the addiction, neglect their own needs, or become overly involved in the addict's life in an unhealthy way. So characteristics of such may include excessive caretaking, low self-esteem, people-pleasing behavior, also have difficult setting boundaries. So this classic context is family members of alcoholics or the drug abuses. Number 7, a leader who is mainly concerned with day-to-day operation of an organization with little regard to the future is called. Now, looking at all those options, you find that option B is the best. So when you look at charismatic leaders, this one they normally rely on personal charm and magnetism to inspire followers, and they are often visionary. For transformational leaders, they focus on future goals, innovation, and transforming the organization. Traditional leaders, they lead based on customs or established traditions, and they may or may not focus on operations. So transactional leader focuses on the day-to-day operation of an organization. Their leadership style is based on exchange or transactions such as rewards for performance or penalties for failing to meet expectations. Transactional leaders emphasize on routine tasks, maintaining the status quo, short-term goals, efficiency, and performance monitoring. They typically do not focus on innovation or long-term vision, which is what differentiates them from the transformational leaders. Also, let me use this chance to also remind you about other types of leaders. Of course, we have said that transactional leaders manage day-to-day activities and tasks and reward performance, while transformational leaders inspire and motivate teams towards long-term changes and innovation. Charismatic leaders, on the other hand, influence others through personal charm and emotional appeal. Traditional leaders only rely on customs and long-standing authority. Autocratic leaders make decisions independently, while the democratic ones are going to involve the team input. Laissez-faire leaders, they take a hands-off approach, so they give freedom to team members to do what they can. Lastly, servant leaders prioritize the needs of others, focusing on team development and empowerment. What is zero budgeting? Zero budgeting means, okay, so when you look at those options, zero budgeting means you're going to use decision making package to justify the current budget. So the first one, you find that this is incremental budgeting and not zero based, while the second one refers to the capital budgeting. The last one is true of zero based budgeting, but not a precise definition. Actually, zero-based budgeting is a budgeting method where every new budget cycle starts from a zero base. This means no expenses are automatically carried over from the previous year. So instead, each expense must be justified as if one new, using decision package that explain the necessity and value of each activity or program. It is designed to eliminate outdated or unnecessary expenditure, improve efficiency, accountability, and cost effectiveness, and prioritize resource allocation based on the current goals, needs, and goals. So we have different types of budgeting. The incremental budgeting adjusts last year's budget by adding or subtracting a percentage, while zero-based budgeting, as you have said, starts from zero each cycle, requiring every expense to be justified. Capital budgeting, on the other hand, focuses on long-term investments like equipment and infrastructure, while the operating budgets will cover day-to-day expenses like salaries and supplies. Flexible budgets adjust based on activity levels, when fixed budgets remain unchanged regardless of the performance. Lastly, performance budgets link spending to outcomes, promoting accountability. Number 9. Mentors differs from preceptors in that mentors, yes, when you look at all options, mentors normally choose who to mentor, right? Mentors normally choose who to mentor. Number 1, mentors, it's wrong because mentors are active guides. They are not passive. And number 3 is wrong because it describes preceptors, not mentors. Lastly, number 4, mentors do assist with career development. So a mentor will differ from preceptor in several ways. A key difference is that mentoring is usually a voluntary long-term relationship between the mentor, where the mentor chooses or agrees to mentor a less experienced individuals, often focusing on personal and career development. So mentors choose who to mentor, while preceptor are assigned to a new staff. Long-term relationship is guaranteed in mentor-mentee, while for preceptor-preceptee, it is usually short-term, structured orientation. Mentor-mentee focuses on career and personal growth, while preceptor-preceptee focuses on clinical skill development and orientation. Lastly, the mentor-mentee, we find that it will be informal and it's more of a supportive role, whereas the preceptor is formal and instructional role, right? Okay. So over delegation involves looking at all these options. Um, you find that C is the best, transferring too much roles from the manager to subordinates, right? From the manager to subordinates. Over delegation happens when a person delegates more tasks or responsibility than is appropriate. This often overwhelms subordinates or appears that the manager is avoiding responsibility. It can lead to burnout among members and decreased morale and poor quality of work if not managed properly. Variables that take only a few discrete values are called. Looking at all those options, these are categorical variables. Categorical variables are also called qualitative or discrete variables. They represent data that can be divided into specific groups or categories. These variables take on limited distinct values such as gender, blood type, or education level. Continuous variables can take any value within a range. It could be height, as an example, or weight. Extraneous variables are the outside variables that may affect the outcome of a study, while outcome variables, those are dependent variables, are what are measured in an experiment. In research journal article, blind reviews means reviewers. Okay, looking at A to D, blind reviews means reviewers are not told the names of the researchers, and the researchers are not told the identity of the reviewers. This is more like a double blind review process where both the authors and the reviewers remain anonymous to each other. This normally helps to minimize bias and ensures a fair and objective review of the research work. Random sampling, random assignments means random assignment means assigning subjects to control group and experimental group such that each group has an equal chance of being selected for the study. Remember, random assignment refers to how participants are allocated to different groups. It could be the control or the experiment within a study. So each subject has an equal and independent chance of being placed in any group, which helps eliminate selection bias, ensures that differences in outcomes are due to the intervention and not pre-existing differences between the groups. It is difficult to obtain meaningful informed consent in qualitative research because the researcher does not know in advance how the study will evolve. This kind of consent gotten by qualitative research is called, yes, this is process consent. Remember this second one, this is not ethical, it contradicts research principles, while the third one usually refers to situations where consent is assumed by participation. The last one, incomplete, this is not a standard ethical term in research. So process consent, or also referred to as ongoing or continuous, is used in qualitative research where the study design is flexible and might evolve over time. Since the researchers cannot fully predict what will emerge, participants are continually informed and their consent reaffirmed at different stages of research. This respects the patient's autonomy throughout the study. So we have different types of consent. We have informed consent, where participants are fully informed about the purpose, procedure, risk, benefits of the study before agreeing to participate. Implied consent is assumed through actions such as filling out a questionnaire or joining a public observation, and this is often used in low-risk studies. Process, ongoing consent, this one is one that is used in qualitative research where the study may evolve. Consent is reaffirmed continuously as new issues or procedures arise. Written consent, this is where they have documented consent, often with a signed form, ensuring clarity and legal protection. Verbal consent, this is spoken agreement, recorded or witnessed, used when literacy or cultural concerns make written consent difficult. Proxy consent is given by legal guardian or representative when participants can't consent themselves, e.g. children and unconscious patients. Number 15, practicing nurses need to develop research critic skills too. Looking at that, you need to develop research critic skills to judge the utility of research findings. Remember the first one, not the main purpose. Critic skills are not for confrontation, but for constructive evaluation. Number B is while critic skills help, conducting a literature review mainly involves summarizing relevant studies, not just critiquing them. Lastly, this is setting where critic skills are applied, but not the reason why they are developed, and that's why option D is the best. So nurses need research critic skills to evaluate quality, relevance, validity, and applicability of research findings to clinical practice. This enables them to make informed decisions about integrating evidence into patient care, a key part of evidence-based practice. Number 16, reflective skepticism is a characteristic of critical thinker means. Okay, reflective skepticism means taking a critical view of established dogmas and practices, scrutinizing them and questioning their current validity. Remember, the first one is close but too narrow and informal. Reflective skepticism is broader and more systematic. The second one, this relates more to creative thinking and not specifically reflective skepticism, while the last one describes reflective practice, not necessarily skepticism of current practices or norms. Reflective skepticism is the habit of thoughtful questioning accepted beliefs, norms, or practices, especially those taken for granted. It involves critical analysis rather than passive acceptance, a key trait of critical thinkers. Number 17, problem-based learning means, looking at all this, problem-based learning, this is learning that results from the process of working towards resolution or a problem. Number 2 is wrong because teachers in problem-based learning act as facilitators where they guide the learning process even if they don't directly lecture. Next is that the next statement is too outcome focused. Problem-based learning emphasizes the learning process, not just the solution. And lastly, while the question is used, questioning is normally used. Problem-based learning includes discussion, exploration, and resource use. Problem-based learning (PBL) is an instructional method where students learn by actively engaging with real-life or simulated problems. The focus is not just on finding the answer, but on the process of inquiry, research, collaboration, and critical thinking that leads to the solution. When an assessment tool measures, when an assessment tool measures what it is supposed to measure, it is said to have measure what you're supposed to measure, validity is guaranteed. Remember, reliability refers to consistency or repeatability of results. That's why in studies to maintain or to attain reliability, you conduct a pilot study so that you can see the consistency and repeatability of the results. Consistency is a general term more aligned with reliability, not specific to measuring the correct concept. Discrimination refers to the tools, this one refers to the tool's ability to distinguish between individuals or groups, not whether it measures the right construct. So validity refers to the degree to which an instrument or a tool accurately measures what it is intended to measure. It's about the truthfulness or appropriateness of the conclusions drawn from the results. So also let me use this opportunity to remind you about the characteristics of a good assessment tool. We need to have validity, so the tool must measure what it is intended to measure. For example, if it is a math test, it's supposed to measure math skills, not reading comprehension. Reliability, it should produce consistent results over time across different assessors or settings for it to be a reliable tool. Objectivity, the results should be free from bias, meaning different evaluators should score the same performance similarly. Usability, the tool should be easy to administer, score, and interpret, considering time, resources, and clarity. Sensitivity, it must be able to detect small differences or changes in performance, while discrimination, the tool should differentiate between high and low performers effectively. Relevance, the content must be aligned with learning objectives or competencies being assessed. Question number 19, an appropriate method that can be used to teach acquisition of psychomotor skills is psychomotor skill, attitude. You should be able to look at demonstrations so that case studies, these are better for teaching critical thinking and decision making, not the physical skills. While micro teaching is used for practicing teaching skills, especially for trainee educators, not psychomotor tasks. Brainstorming encourages idea generation and problem solving and not physical skill acquisition. So for physical skill acquisition, demonstration is the best. Demonstration is ideal for teaching psychomotor skills, skills involving physical movement, coordination, and the use of motor skill areas. Watching a procedure being performed correctly helps learners visualize, imitate, and practice the skill step by step, which is essential for muscle memory and accuracy. Lastly, we have the decision-making hierarchy is called in management, this is scalar chain. Remember, span of control refers to the number of subordinates a manager can effectively supervise, not decision making. Decentralized decision making refers to the decision making authority being distributed to the lower levels. It is a style of management and not the hierarchy itself. Centralized decision making is the opposite of decentralized, where decisions are made at the top, and again, this is a style and not a hierarchical structure. The scalar chain refers to the line of authority within an organization, running from the highest to the lowest levels. It defines the hierarchical structures and the flow of decisions and communication, and this ensures clarity in reporting and accountability. Hello guys, remember we are looking at paper 2 topics, and paper 2 topics you must be sure that you have to look at introduction to community health nursing, review primary health care, environmental health, communicable diseases, community health and community diagnosis, special health issues, home-based care, mental health and psychiatric nursing. We also have sociology and anthropology, research in nursing, leadership and management, teaching and learning methodology. Those are the major topics for paper 1 nursing. All right, guys, you can still review the question and share the feedback. Let's find out. See you.